Well, welcome everybody to the Spine and Rehab Specialists, episodes number 9 of our podcast series. So today we're going to talk about whiplash and a lot of things that, go around that. So with me today I have Dr. Andrea Goche. Yeah, Andrea, welcome.
Hello.
And Dr. Earl Hayden.
Hey.
All right. So, whiplash. I think first for our audience, we need to kind of explain a little bit what that is, right? So, a lot of times with whiplash, we think about, this is car accidents, right? Because it's really the force of being hit and your head being thrown backwards, forwards, in a whipping motion. That's why it's called whiplash. But it's not just car accidents, right? So, Earl, can you give me some other example of what, could cause a whiplash injury?
Yeah, we can definitely see a whiplash. It can happen with a fall. So just that sudden stop. Doesn't always have to involve a direct head contact. We see that with sports injuries. So the first thing that comes to mind is football. So if we're accidentally getting that helmet-on-helmet contact, anything that can jerk that neck.
Yeah, because I think, in football, how many whiplash injuries does somebody have in their career? Probably a ton of them, right? So, Andrea, can you think of anything?
Yeah, I mean, it can be anything that, as he said, produces a sudden stop or a sudden movement of the neck, like even using a roller coaster or being on a roller coaster. It's another way we've seen people getting injured in that manner too.
Yeah, definitely. Physical abuse, getting beaten up by somebody, whether that's spousal abuse or just a fight up on the street, you get, knocked in the head with a fist, that's probably going to cause a whiplash. So, let's see, do we have other ones?
Let me see. Yeah, I guess kind of random. I guess is even, let's say, playing with the kids, or actually playing with your pets, and you have a little hyper dog that kind of jumps up. Maybe that kind of knocks your head back a little bit. So just any type of accident, just random things that may just jerk that head back, strain that neck a little bit. Yeah.
Yeah.
So one of the things to consider with whiplash is what happens within the body or the systems that are being injured with this type of injuries. And it's a variety of things. We have to look into the brain, we have to look into the neck, we have to look into the shoulder, the back, see what's being injured by this sudden movement. So as physical therapists, we definitely see patients with this type of injuries all the time, but we have more work to do as just them knowing that they have a whiplash.
Yeah, because a lot of times, obviously, we're going to look at the neck because that's probably the primary complaint they come in with. My neck hurts because I was in a car accident, or my neck hurts because of this. But it goes way beyond that, right? So there's a lot more symptoms than just maybe neck pain and maybe just a headache that comes from the neck. Or can you think of some other symptoms that that happen?
I think one of the biggest things that pops in my head is just anything kind of spreading away from the neck, going down towards the shoulders, starting to run down the arm. We're starting getting some burning pains, numbing, tingling, loss of strength in either side. And sometimes it doesn't always come on right after the accident or fall happened. So that could be kind of lingering, just kind of building up slowly. And then our patient or client won't even notice it. They'll wonder, where did this come from? Because they maybe just have like a little bit of that soreness right after the accident, just in the neck, and then everything else just kind of gradually comes on a few weeks, a month down the line. So it becomes kind of weird for some folks.
Yeah, and then we definitely have to look at the brain as well, because a lot of times the force that happens, whether it's a car accident or a football injury or something like that, you're likely also to hit your head at some point. But even without hitting your head, that force, your head gets whipped, back and forth. There's definitely a force, happening in the brain, right, Andrea?
Yeah, correct. And that's basically the mechanism of injury to get a concussion. And if you guys don't know much about it, a concussion is basically a mild traumatic brain injury where the brain hits the front of the skull, the back of the skull, and now you have some hemorrhage or some inflammation going on. And that can come with other symptoms, as Earl was saying. It's not necessarily only the physical symptoms with the neck, the back pain, the numbness, tingling. It can be confusion, it can be dizziness, it can be balance impairments, it can be difficulty concentrating or coordinating. Like all of these things can come from this specific injury, and we don't even necessarily relate it to it all the time.
Yeah, and we've done a lot of stuff with concussions here in the clinic, and I remember from a lot of the research that we did preparing for that is it's even just a chemical reaction. It's not, obviously you can have bleeding in the brain or, things like that, but it's a chemical reaction happening in the brain that really sets off all these things. And a lot of times, patients are, wondering why that happened. I was in a car accident and now I can't remember things. How is that related, right?
Exactly. And again, going back to us being physical therapists, is something that we see, and it's something that we analyze and assess when we do initial evaluations or during treatment. And it's something that can be treated even for someone that's not necessarily related in the cognitive area like us. But definitely it's something that we can address, and we need to pay attention to it, because knowing or having those symptoms can definitely affect how you recover with the other physical symptoms that we're talking about, like the neck pain, the mobility, and the soreness and all of that.
So it really does take a very thorough physical therapy evaluation to determine what's going on. So this isn't something that's just a quick eval, 5 or 10 minutes in the room with a patient. We really have to dig through all the different symptoms that can be related to it, that the patient may not even think it's related. I mean, they're here for their neck pain because that's probably the diagnosis, and they don't even think that all the other stuff is related to it, and then we can address it. So you want to describe a little bit on that evaluation aspect, I guess really either one of you guys.
Okay. I think one of the things that we need to take into account is whenever the patient does finally come into our clinic, it's not always right away. So maybe this has had time to progress and build up over time. And so things I'm looking at is just the minute they walk in, if we get to see them come out of the walking, or how are they standing up? How are they moving? Is it slow? Is it cautious? Are we seeing some body sway, some different signs of dizziness and loss of equilibrium? And then you start asking them just basic questions like, are they getting dizziness? Are those symptoms changing throughout the day? Is it disturbed with their sleep? Watch how they turn and move their neck. Is it cautious? Is it slow? There's just, it's very detailed.
Yeah,
actually.
Yeah, definitely. And the history part of it, like basically what the patient tells us, is one of the most important aspects. And as he said, we want to know how long ago was the accident or the injury, because the symptoms are going to present way different 2 days after the injury versus 2 weeks after the injury, and we need to take into consideration all of that. Now, as he said, like when I know I'm going to have a concussions patient or a neck patient, I already know I'm going to be in the room for a good 45 minutes because I have to look into all of these areas. And as physical therapists, we don't only see like the neck pain or anything like that. We're going to do a vestibular assessment, make sure that you're not having weird eye movements that might be producing your dizziness or your difficulty with balance and ambulation and all of that. So definitely history part is going to be very important. We're going to want to know how it happened, when it happened, what did you do, what type of treatment have you done, and definitely what is being affected in your daily life, because at the end of the day, that's what we do. We want to get you back to where you work, get you back to your functional activities. Like if you are a teacher and all of a sudden you cannot focus, okay, let's work on activities that might help you with that are still related to what we do in regards to physical therapy.
Yeah, because we really have to get a good baseline of where were you, because that's hard for us to gauge, right? I mean, I can look at, neck range of motion, how many degrees is somebody supposed to have, and if we're not there, then we'll shoot for that. But brain function is something totally different. So we have to have that really good evaluation of a patient, asking questions on how were you before and how are you now, and how is that different?
Yeah, definitely. And one of the things that we're going to address first, because it's what we do, we love using our hands, is going to be the neck. We want to look at the neck. As Harry said, we're going to look into range of motion, strengthening, and people think of strengthening of the neck just as the head movements. No, the neck depends on so many other muscles, like the muscles of the shoulders, the muscles of the upper back, the muscles around your shoulder blade. All of those areas are going to be addressed. So for sure during an initial evaluation, we're going to be looking into all of those aspects. Okay, once we defined what the impairments are, okay, we have to move into treatment. You want to talk a little bit more about what we're going to do for that?
Yeah, definitely. So obviously, depending on the acuity of the problem, like how recent was the event and how severe was it, obviously we're going to look at how do we need to treat pain, because a lot of times that's what the patient comes in with, on day one. Hey, my neck hurts, my head hurts, this is what I need help with. So obviously that's kind of the first thing that we're going to look at. And we have so many different ways to treat pain that are not chemical, that are not medications, or injections. And that's the wonderful thing I think about physical therapy. We have so many things. So we start with our hands, definitely doing a lot of manual therapy techniques, whether that's soft tissue techniques or some joint mobilizations and, things like that, and then progressing into stretching and everything that, a lot of times patients may not realize, but that's actually very, very helpful for addressing pain.
Yeah, definitely. And many of our patients, I don't know if it happens to you guys, but they have seen 2 or 3 doctors before they come and see me, and none of them have touched them at all. Like, they have even placed their hands, okay, your neck hurts, okay, move it a little bit, move it this way. And that's all they do. Like, nobody puts their hands on their neck, when usually just doing some simple stretching or some simple joint mobilizations can make a big difference. And we see it when they come back the following day or the following visit. It's like, oh my gosh, it got so much better when the patient has been trying with medication, injections, modalities, and nothing seemed to help. And just spending a good 15 minutes on the patient working on their neck can make such a big difference.
Yeah, and I think it's amazing that we seem to be the only one really doing that.
I think another thing that to keep in mind is where were they? I think you said that as well, Andrea. Where were they before? So, are we the first person that the patient saw? Did they go see the doctor? Were they referred to a chiropractor? What's going on with that? What type of treatments did they receive? Was it only modalities? Did they have any type of movement? So we have to start with using our hands, getting that pain under control. But at some point, we have to get the patient moving.
Yep.
And if we're not doing that, 1, those muscles are not going to get stronger. 2, that person might continue guarding. They won't learn to overcome that fear of movement because, they're in pain. So we have to get over that hump and get them back to whatever they need to be doing.
Yeah, it's like a vicious cycle. Patients are in pain, you don't want to move, you stop moving, and then the pain worsens because you're not moving anymore. And then it just keeps going south both ways, pain-wise and movement-wise.
Yeah, and I think a lot of times patients are just too scared to move. They think they're gonna, break something or so by moving. Yet our prescription is, no, you gotta move. We need to get you moving. Guided movement, not necessarily, go run a marathon or anything, but we definitely need to get our patients moving because, that movement really helps with pain and helps with a lot of, problems. That's why I always like us being described as the movement experts. I think that typifies, physical therapy for sure. We're the movement experts. We get people moving, joints moving, people moving.
Definitely, and even research has shown specific for concussion patients, for example, which is one of the main results of a whiplash injury, is that if you start moving soon, like let's say within the 2 weeks of the accident, you have a better prognosis, which basically means that you're going to recover faster and better than someone that's very guarded or very scared to move and they just rest until figuring that the pain will go away if they don't move, and then it's the other way around, it gets worse. So research has shown that yes, we want to rest, definitely. If the injury happened acutely a few days ago, you want to have 1 or 2 days of rest, mobility, letting the inflammation process go down and all of that. But as soon as those first initial couple days are done and are gone, we need to start moving. And as you said, it's not like we're going to have them run a marathon or anything like that. It's just a gradual, progressive, well thought, designed exercise programs that we're going to give you to get started with mobility. And usually the first type of exercise are going to be for pain management, range of motion improvements, and then we move into the strengthening area.
Yeah. And earlier you mentioned some of those modalities that in some places that's the only thing that's being used. Don't get me wrong, we do use them, but we use them in order to allow somebody to start moving. Right, so maybe it's some heat before or some ice afterwards, but it's never the sole treatment because to me that's not what you need to do to get somebody better. So yeah, we use them. Yeah, we'll use the heat and stim or ultrasound or ice and anything, but really just as a means of getting people moving. So and I think that's just important. If that the only thing you're getting is some modalities, some heat or ice or stim or so, then I don't think you can really getting true
physical
treatment.
therapy.
Yeah, that's
not physical therapy
Right, it really
necessarily.
Right. I think that was also something that I think criticism against people who are claiming to do physical therapy. We've seen that with some doctors' offices back in the day or different other clinics, and they're just doing hot pack, cold pack, and
ultrasound. Let's ultrasound your neck.
Yeah, there you go.
Yeah, exactly. And it's like, yes, there's a place for it, but it should never be the mainstay of what we're doing?
No, the mainstay of our treatment, of our work, is going to be to get you back to function. And as we have mentioned, with whiplash injuries, it's going to be a ton of things happening at the same time. And it's something that we can still address. Like if you are having difficulty with concentration or dual tasking, guess what? You're going to be doing some sort of exercise that it's going to require you to be concentrated or to do two things at the same time. I have had kids working on balance activities while they have to name different cities or tell me their addresses or different things just to work on that dual tasking, so we can address the cognitive area that's been affected as well as the physical area that's been affected.
Yeah, I think that's the beauty of our profession, is that we get to integrate all these different things. So we're not just on the physical aspect, we can have, some of the cognitive aspect in there as well. And I think that's great.
And I think also one of the things that we can address very well with physical therapy, and people don't usually think about it, is headaches or migraines, because those can be coming from the neck, right?
No, absolutely. That's one of the most common things. That's always the first thing I think of when people come in and they're telling me that, okay, I'm getting headaches, and I don't know if it's because I'm just stressed or I just carry all the tension in my neck or what's going on. But then you start asking them about their symptoms, and it changes with head positions, whether they're slouching for long periods of time, or if they're laying down in a certain position, or are they retracting, whichever. So that's a big part of what we have to do, is always looking for those different signs and symptoms and getting those clues to help guide us on how to get that person moving again.
Yep. Yeah, because we definitely want to get it moving, but we don't want to overdo it either, that their symptoms get worse. So, and then of course we have the progression into strengthening exercises and ultimately returning back to function. So, Andrea, what kind of strengthening exercises would you typically use on somebody who has whiplash as a in their history?
Usually I am going to start with very light stabilization exercises. And for you guys that are not in the physical therapy world, basically stabilization exercises are activities that we do to strengthen the areas around the neck that provide stability. I always like to use the example of a brace. Usually when someone has an injury or their back hurts, they usually put a brace on, and it feels better. The reason why it feels better is because that brace providing stability, the stability that the muscles are not doing. So basically one of the very initial strengthening exercises I'm going to do is stability activities, where I strengthen those muscles that should provide that nice comfort to the neck, knowing that it's nice and stable, and if I have to do a sudden movement or if I have to lift or carry, my neck is going to have the strength, or the muscles around the neck are going to have the strength to maintain the neck in a comfortable position without it hurting. So that's definitely one of the first things I'm going to do, is the stability exercises for the neck, which usually involves activating the shoulders, activating the upper back, activating the prescapular musculature. So people sometimes look at me kind of weird, like, why am I doing exercises for my shoulders when my neck is the one that hurts? Well, it has a purpose. The reason for it is because, your neck also has some stability coming from the shoulder musculature, because they share, like they come from here but move down here. So definitely that's one of the first things I'm going to do. What about you, Earl?
For sure. I think, getting setting that foundation of strength, one, will help reduce the pain for longer periods of time, because that's the thing, we can do all this stuff in the clinic, but sometimes that relief is temporary. So getting everything stronger again will definitely help that pain relief stay a lot longer. The other thing I look at is maybe some things I might avoid a little bit is doing a lot of overhead reaching and whatnot, because that tends to compress the neck a little bit more. So that might be a little bit uncomfortable, but gradually as the symptoms come down, start working on those overhead reaching movements. And especially if you have an athlete, somebody who does some overhead activities, and you're throwers, volleyball players, or gymnasts, or someone in dance, you need to be able to get those ranges back. So at the beginning, a lot of pain management, a lot of stability, but then eventually you just got to progress to whatever they're doing. So really, there are no true limitations at that point. You have to just get them as strong as possible and get them back to moving.
And there's some really very specific neck exercises that we do as well. We can work on deep neck flexor exercises that may start with somebody laying down on their back and they're kind of doing a chin tuck and then lifting their head up. We may use the little stabilizer, which almost looks like a blood pressure cuff that you're having to exert a certain amount of pressure. And then we can go into very specific neck exercises, either using some sports cord with a harness around their head, or we can get people on the multi-cervical unit, which I actually wanted to touch on a little bit. So we have this multi-cervical unit, we've had that for the last 20 years or so. It's specifically, designed for rehab for neck patients, with Whiplash definitely being a big category in that. And we can do isometric strength testing on it, so we can already determine what their strength is on that. And then it has literally a little weight stack behind it, and yes, it starts with like a quarter of a pound. That you can go through all different kind of movements of your neck and literally make those neck muscles stronger. And there's some really good research behind that on how much that helps people recovering from whiplash. So we definitely can get some very specific neck strengthening in. We can determine exactly where the weakness is, and then go into strengthening using all these different tools.
Yeah, definitely. Once we're strong, once we're ready to go, your pain is less, your strong is more, or is better, let's get you into function. Let's see, okay, are you a dancer? Tell me what you have to do, and we're gonna practice doing that. Are you a worker person that works for USPS and have to do a bunch of lifting, carrying, or whatever? Okay, we're gonna simulate all of those activities just to make sure that you're ready to go back to where you were before the accident. So I think that's what we do. I think we do a great job treating this injury. So please come see us. If you get injured like that, we can help.
Yeah, and I think wherever you go, make sure you get the appropriate help. Make sure that evaluation that you get is very thorough and looks at everything, not just at one or two neck movements, but really looks at all the symptoms that you're having and addresses all of them. And make sure that the therapy that you're getting truly is hands-on stuff, right? So yeah, good, awesome, guys. Thank you for coming out for our podcast. Thank you, Andrea. Thank you, Earl.
Oh, thank you.
Awesome. And look for our next one coming up in a couple of weeks.
Bye.
Bye.
Bye.